much, Simon, and thanks for inviting me to be part of what I think is a very interesting and important symposium. Coming as I am late in the programme, you've already been bored to tears by the EQUIP study, which is Tim Dornan's study from the northwest of England, showing that doctors currently in the NHS are not safe or effective prescribers, at least not all the time. And my job in the next 10 minutes or so is to try and work out whether a student formulary can address this problem. Here's a little bit more detail from the EQUIP study, and anyone who's interested, here's the website where you can find it. They looked at 19 acute hospital trusts on 7 census days, and some poor person had to go through over 120,000 what they call medication orders. And as you now know, they found for every 100 medication orders that there are 8.9 errors. We think that those poor F2s who have been much castigated are probably just starting their fledgling careers as independent prescribers and so are making the most mistakes. And perhaps the more protected F1s are getting away with their perhaps lack of skills in this area. But as we know, errors are made by all grades of doctors. As the speakers before me have very eloquently pointed out, this is not just about education. This is a very complex problem, and errors are made due to systems failure, problems in institutions, and problems as well with doctors' knowledge and prescribing skills. So, in this incredibly complex situation, can a student formulary help? The Oxford English Dictionary defines a formulary as an official list giving details of prescribable medicines. And in my talk, I'm going to consider both what should be on that official list and then pay a little bit of lip service to perhaps what details should be available for drugs on that list to support prescribers. And I hope I will lead up to the grand finale of Simon talking then about perhaps what might be in a formulary. This is one of the studies that Sarah probably considered in her systematic review. This is published by De Vries and colleagues in the European Journal of Clinical Pharmacology in 2008. What they did is they recruited over 500 medical students from 8 universities around the world, and they gave them a prescribing skills test based on 4 conditions: essential hypertension, osteoarthritis, acute bronchitis, and gastroenteritis. And you can see in the blue bars the scores, an arbitrary number for the sake of this talk, that the students obtained at the baseline. They then randomized the students to 3 groups. They had a control group and 2 groups that received a student formulary. The students in the control group had no further training. 5 weeks later, they retested the students. And what you can see in the purple bars is that the students who received training by a student formulary improved in their prescribing skills score, whereas the control group improved very slightly, if at all. So perhaps a formulary is helpful in helping students obtain prescribing skills, at least in an exam and not in the real life scenario. So does the type of formulary matter? Well, you can see here that I've detailed an existing formulary and a personal formulary, and I shall go on to explain what they are. This is the WHO recommendations from the Good Prescribing Guide we've heard about. They recommend that students should choose their own list of drugs that they will prescribe regularly, and they call these P, or personal drugs. Now, having taught students for many years in clinical pharmacology, at least at St George's, I've found that there are some P problems with this. We have, in the UK, over 3,500 drug preparations licensed for use in our British National Formulary, and junior students simply don't know where to start. It's also important for me, and I'm sure all of you, in that we have to work out how to support our students and to teach them. And if they've all got a completely different drug list, it's very difficult for us to know how to teach them and also how to assess them. So there is some data showing that actually the type of formulary doesn't really matter. And this is again from the De Vries study. You can see here that I've divided the groups this time into blue for control, purple for existing, and green for personal formularies. The existing formulary, the students were given appropriate prescribing guidelines for the 4 conditions, I think written in Oxford. In the personal formulary group, the students were asked to make an inventory of all drugs available for treatment of the 4 conditions and then choose drugs for prescribing from that list. Now what you can see is that it's not really the type of formulary that matters so much, but more the type of teaching that you get and your finding out skills. So students, I think it was in Russia and Yemen, I think, who had a very traditional didactic curriculum, benefited much more from the finding out experience. Whereas students who are already having a problem-based experience, you can see even the control group improved. They probably did the exam, found they were bad at it and went to find out off their own bat, even without the existing formulary. So we at St George's and with Andy Webb at Barts have taken the view that it is okay to tell the students which drugs they need to know about. And we've done some work working out which drugs those should be. What we did was we looked at the drugs prescribed most commonly in the primary and secondary care setting to develop a core drugs list to support student learning. We looked at the primary care prescribing information, and initially we used the 2006 data, and you can see there were 751 million prescriptions, and this information was from the Information Centre in the NHS. We also did a much smaller secondary care audit, both at St George's and at the London Hospital, looking at prescribing on medical and surgical wards, where at least 2/3 of our F1 doctors are working. And in this audit, we looked at nearly 8,000 prescriptions. And in our prescription charts, we miss out emergency drugs because they tend to be prescribed in accident and emergency. So we also looked at our emergency guidelines. Now, I'm not going to spend the rest of the presentation telling you what the top 100 drugs are. But suffice it to say that the first 73 of the drugs made up more than 0.1% of prescriptions in both primary and secondary care. Or sort of more than or equal to. Robin's looking puzzled. And you probably would have guessed, if I'd asked you to guess, that they would include proton pump inhibitors, statins, ACE inhibitors, and aspirin in the top 4. We also included in our list, bearing in mind that over half of our doctors will go on to become general practitioners, the highest ranked drugs in primary care alone, topical steroids, vaccines and the oral contraceptive, and the most commonly prescribed drugs in secondary care alone, including heparin and IV antibiotics. So it's all very well having a list of drugs for students to learn. We've heard already they need experiential learning and doing stuff they'll actually do as F1 doctors. So is this list developed in 2007 going to be useful for doctors when they qualify? The next thing we did is repeat the study to look at the stability of this core drug list. I'm going to talk you through the primary care graph first, and then hopefully the secondary care will become self-explanatory. These are Bland-Altman plots. What we did was we ranked the drugs from 1 to 100, where 1 is the most frequently prescribed and 100 is the least frequently prescribed. On the x-axis, you can see the average rank for the drugs, and on the y-axis, you can see the change in rank for the drugs between 2006 and 2008. A positive change indicates that that drug has moved up the top 100 in primary care, and a negative change indicates the drug has become used less commonly. And you can see, in fact, that there's an amazing stability, certainly in primary care, where there are hundreds of millions of prescriptions included in the analysis, in the top 100 drugs. Importantly, you can see that 97 of the drugs that the students perhaps would have learned about using that list in 2006 were still in the top 100 drug list in 2008. The primary care data looks a little bit more like someone with chickenpox, but essentially 90 drugs remained unchanged in secondary care. And I'd like to remind you that this only is 8,000 prescriptions and not hundreds of millions as seen in the primary care set. So the drug list is stable over 2 years. But do the F1 doctors actually use the drugs that we have in our list? This is the results of a prescribing survey in F1 doctors from 39 trusts across London, and 148 doctors took part. What you can see in the graph on your left is that 2/3 of the drug were prescribed often or sometimes by the F1 doctors, and only around 10% of drugs on the list were never prescribed. And in fact, these were the emergency drugs. The F1 doctors aren't let loose on patients with atrial fibrillation or heart failure. You can also see on the right of the chart that F1 doctors very seldom prescribe drugs that are not on the list. 3/4 of the doctors had never regularly prescribed drugs that were not on the list. So F1 doctors are using our core drugs list. And how does this relate to prescribing errors? This graph compares the frequency of drug use in the core drug list on the x-axis with the proportion of the prescribing errors associated with each drug class from the EQUIP study. And if I had a correlation like this in my normal research, I'd be delighted. And what you can see is basically the errors the doctors are making are in the drugs that they're prescribing most frequently. And you can see the most commonly prescribed drugs are analgesics and opiates, closely followed by antibiotics. So the drugs that are prescribed frequently are the ones that the errors are made in, and they're the ones that the doctors need to know about. So a formulary is an official list, as I've hopefully described, but it's important also that we don't just have a list of drugs, that we have details of these prescribable medicines, and that the prescriber is learning the right things about these drugs to use them safely and effectively. The EQUIP study says, as again we've heard many times today, that the knowledge that's lacking for students or junior doctors is a complex and contextual type of knowledge, more than just the underpinning theory. And also they say that more could have been done during undergraduate education to link theory with practice. And it's about developing expertise in the complex context of clinical practice. So what else should be in this formulary about this top 100 drugs to get students learning the right things? Well, perhaps it's a complex and iterative process where students start by learning the basics in their early days, the pharmacology of individual drugs, the pathophysiology of diseases. They then maybe start to learn about special circumstances, and they're marrying these with the clinical skills of the medication history, of drug administration. I think students should be thinking in bundles of drugs, not individual drugs. So are they on the right drugs for heart attacks? Are they on the right drugs for chronic bronchitis? And how do they interact? They need to be thinking about the guidelines and evidence, and very importantly, learning about policy, safety, and doing shadow prescribing for as much as possible, both at simulated and in the real clinical environment. And so finally, when they're actually prescribing, they've built all their skills on their formulary of the core drugs list so that they're able to do this safely and effectively, but not completely safely in the NHS. So I think this really brings me to Simon to talk to us about the Prescribe project, which hopefully will include lots of these things in this context of this student formulary. And I suppose it just leaves me to answer my own question. Is a student formulary the way forward? Yes, and as everybody else here has said, only part of the way forward, clearly indicating a need for a team approach. I'd just like to acknowledge all the medical students who have massive enthusiasm for clinical pharmacology, who've done all this work, and these are, as Jeff will tell us, our future. Kirsty, Hannah and Sati, who did all the hospital audit, Adele, who at St George's, Adele, who did 2 audits of the primary care data, and I think one of Andy's registrars at Barts in London, Dr. Rull, who did the work at Barts. I haven't given you the top 100 drugs, but if anyone would like them, there's my email address. Thank you.